Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have and will follow up on questions he does not have the opportunity to address. You will receive an email within a week following the webinar that will include instructions to download a copy of the presentation. It is now my pleasure to introduce today's presenter, Scott Becker. Mr. Becker is the publisher of Becker's ASC Review, Becker's Hospital Review, and Becker's Spine Review. Scott is also partner and chairman of the healthcare department at McGuire Woods in Chicago. Mr. Becker received his JD from Harvard Law School and his BS in Finance and Accounting from the University of Illinois at Urbana-Champaign. I'm now going to turn the floor over to Scott to begin today's presentation.
Great. Kathy, thank you very much, and thank you for joining us, those on the phone. We're going to spend time today going through 5 sets of issues, and throughout the discussion, if at any time you want to ask a question, there's a way to enter it on your screen, and we'd love to answer questions throughout the discussion as well. The 5 topics we're going to talk through are, starting with key strategic issues first, how hospitals can evaluate themselves, what they can look at, and some of the big trends that are facing hospitals and health systems. Second is 8 to 9 observations on physician-hospital alignment. Third is the sustainability of an independent hospital and whether or not it could stay the course or has to look at larger affiliations or other strategies. Fourth, the evolution in ACOs and some thoughts and uncertainty as to where things are going with ACOs. And finally, fifth, time permitting, we'll touch on 5 to 7 other sort of issues facing hospitals and health systems and that have different impacts on healthcare as a whole. With that, let me turn to the first slide and take this through a number of questions that we look at in helping an individual hospital evaluate its own strategy and how it looks at the universe. So, Kathy, if you move to slide 3 on the webinar slides, but the first real slide. In terms of key strategy, and I'll walk through this very quickly to set up the rest of the presentation. When we work with particularly an independent hospital, even a dominant independent hospital, we start with a number of questions to evaluate its market situation and helping them assess what their position is and what their aspirations are. So we look at things like, are they the go-to hospital in the area? What is ultimately their key strategy? Is their key strategy to be sort of the market-dominant hospital in an area, the market-dominant hospital in an area in special areas, or is it to be sort of very lean such that it could survive based on a relatively reasonable amount of revenues, even if it's not the dominant hospital in the area? What does it have to do to thrive and survive, and can it be at a spot where it's dominant, and if not dominant, great in specific niches, or third category is to be very lean and have low enough operating costs that it can survive and still do things well, even if it's essentially not dominant. Second main concept is we look for hospitals to be in a spot where essentially, and this has become harder and harder, to be a place that payers and networks cannot go around. Can the hospital still make itself indispensable? This is a lot easier to do in secondary geographic areas or rural geographic areas. It used to be doable in major metropolitan areas. For example, Montefiore can still do it in the Bronx. At one time, Northwestern Memorial Hospital could do it here, essentially be in such a dominant position, even a major urban area, that payers and networks couldn't go around it. I think it's harder to do that today. Montefiore, I think, can still do it in the Bronx because it's really the sole hospital with a very large population around it. Third issue that goes to strategy and how it looks at itself is where is the hospital in terms of its physician network? Is it deeper than everybody else? Is it deep enough to look at and examine different managed care strategies and still thrive in a fee-for-service world? Does it have a lot of risk as to its top admitters? For example, is it in a spot where of its top 25 admitters, 5 to 7 of those do not have financial relationships with the hospital and that are on the market looking to move to other hospitals and take other actions? So the strength of the physician network, and I think increasingly the sustainability financially of the physician network as well. Fourth issue is, what are the aspirations of the hospital? And a lot of this is a much deeper discussion than today. For example, is it intended to be the best management team? Is it intended to be the hospital and health system, sort of like Advocate became, where it was ahead of others in terms of ACO and shared saving efforts and ultimately network development? Is it intended to own a certain geographic area where it's indispensable, or is its goal to be the very deepest physician network? Sort of how you define what you're trying to be. Other potential aspirations are, the best quality program. Not just meeting Maslow's hierarchy, lowest common denominator test for quality, but actually being the best. Can you be great, so great in the area that people view it distinctly? I was on the phone this morning with a small hospital who talked about how it had done such a great job of collecting quality data in a specific area and how it thinks it's way ahead of others in that arena. And I think that's probably very healthy. Whether or not it will actually get paid for that or will lead to sustainability, I don't know. But essentially picking a strategy that ultimately leads back to a situation where patients want you so badly or payers and networks can't go around you, which is increasingly, again, a challenge. Next concept we talk about strategically, just to cut right to the chase, is to know your big money areas. If you're like most hospitals, these big systems, it's often orthopedics, oncology, cardiovascular, neurosurgery, maybe imaging, maybe some other areas. But first and foremost, from consultant speak, knowing your cash cow areas, protecting those while you invest and grow other strengths and other goals that you might have as a system. So know where your money's come from. The next issue, F, is really not two different things we've discussed earlier. It's understanding your competition and your competition as to payers and networks. It's how much threat you have that other payers develop a much deeper network and much deeper relationships with payers that they do, in fact, go around you. Are you in a geographic area where there's competitive hospitals of enough stature, or even if they're not right in your backyard, are they close enough that payers and competitive chains and systems can grow around you? A next issue that we hear more and more about, and I think it's very important for depth of leadership issues, to an extent for purchasing issues and a few others, is enough scale to normalize cost. And the discussion on how big a scale do you have to have is had in many different ways in many different boardrooms. I've been in some boardrooms where it's a $700 million a year institution, and they quite frankly think they're way too small to survive in the long run. And that could be because they need to do a new hospital, or they have other reasons where they think they're too small. If you look at the merger of the Stanford system with the Minnesota-based system, which are $3 billion systems, they're probably of the mindset that they have to be very big to be critical to the nation's healthcare delivery system in the future. The discussion of can you survive, we still see plenty of $60 to $100 million revenue hospitals that are niche dominant still do extremely well. So there's this great question of, do you have to be a $2 billion system? Can you be a small system? Or like some prognosticators, do you believe that ultimately you've got to be one of the 40 to 50 remaining large systems in the country that some people predict will happen over the next 8 to 10 years to really thrive and survive in healthcare? Either way, I look at this as you have to be big enough to keep on retaining great physicians and great management, and also to take reasonable bets, reasonable risks in a whole variety of places going forward. Whether it's for amortizing cost for talent issues, for purchasing issues, recruiting issues, or taking some risk issues, you have to be big enough to do those kinds of things. And then whether or not you could survive at that size, we'll talk about in the fourth item today, sustainability, the third or fourth item later today. In terms of just a basic concept is because so much of payment today is not just from four payers, but from a variety of sources, patients, individuals, etc. You have to be great in revenue cycle, billing, and collections. There's no way around it. It's just your cash flow, and you have to be great at those things. A next thing that a hospital has to look at in terms of strategy and its ability to stay effective and to execute is, what kind of investments does it need to take? Does it have a solid balance sheet? Does it still have great margins? And again, you have to strengthen the hospital while things are going well, because trying to do so in a downward cycle is nearly impossible. It essentially comes down to a lot of situations. Do you have a solid enough balance sheet, enough money, enough capital, enough margins to take reasonable risks and take reasonable initiatives and, quite frankly, to double down on the things that go well? Do you have enough money and income that if management makes an error in a set of hiring on the physician side, in a risk contract, in buying an IT system, and whatever it is, that the hospital system can afford to take some errors and not be in a spot where any one error or two errors will essentially kill the hospital system. A next set of discussions, and we flip forward to the next slide, is just a few overview issues on what's going on in the general healthcare world in the hospital arena. And many of this will not be news to people, but we'll just walk through some of the core concepts very quickly. Obviously, more disruption in healthcare at this time than any time in the last 10 years. That stated, a ton of uncertainty as to actually how quickly things will move out of one method of getting paid into another method of getting paid. What we're seeing in a lot of systems is slight erosion in profits as opposed to the doomsday scenarios people have expected. When you hear people talk about the healthcare industry, if we really did see serious migration of business to either healthcare exchanges or to other types of payment methods, people talk about the potential of a 10 to 20% reduction in revenues at systems. If the reality is that many systems are living on 1 to 7% margins, the concept of a 20% reduction in revenues is cataclysmic. I think what you'll see is erosion in revenues over time, but it'll be shocking if it happens as quickly as some people have predicted. Of course, the jury is still out on that. But you do see tremendous disruption in a lot of people sort of living very much still in a fee-for-service world as they evaluate the new potential dynamics of how they will get paid. Obviously, everybody's seen this, tremendous increases of employment of physicians nationally. We've seen this go up to about 50% nationally, much higher in different specialties. What we see in different specialties is when specialty reimbursement is reduced enough, physicians often run to become hospital employees, even if traditionally they had a very dim view of being a hospital employee. Again, we see often the situation, reimbursement for physicians, this happened in cardiology, drops by about 20%. Everybody becomes employees. In contrast, we've seen in some markets in the country, orthopedic physician incomes drop by 5 to 10%. At the 5 to 10% drop in income, what we see is physicians look carefully and start to explore physician employment by hospitals, but they don't jump to it nearly as quickly. A third item is, I think, one of the things that will happen with the looming shortage of physicians, and this is very different based on urban markets versus rural markets versus semi-rural markets, is the distinction of, are there just enough doctors to ultimately keep hospitals all working going forward? You'll have the patient demand. I don't think that's really going to be an issue, but will you actually have the number of physicians at many institutions to make this work? We're just on the phone with the CEO of a major health system. His revenues are up. Their revenues are up at their system. Not so much because anything they think they've done specifically right, though they've done a lot of things right. Their margins are up because one of the local hospitals in their greater area closed, and that's led to the migration of patients to their systems. Their census is up, but it's sort of almost for bad reasons, not good reasons, their census is up. And I think you'll see more of that as hospitals can't just, as some small hospitals, particularly in markets where there's serious competition, can't figure out how to survive, and it's either turn their keys over or close, and you've seen a little bit of that, and I think you'll see some more of that. We've talked about D, the slow erosion of per fee-for-service medicine, and again, when you talk to some of the Medicare committees, they believe we should get rid of fee-for-service entirely. The reality is you're still going to have to pay people for work, and what you're now seeing is the productivity numbers of employed physicians going down, at least latest studies show, going down significantly compared to private practice counterparts. And if you really move everybody to a system where people don't get paid based on their productivity, it will be fascinating to see longer term what that has an impact on in terms of actually delivery of service to patients. I don't know if the government's concept is, well, what we really want is set fees where no health care is really delivered, and thus we could pay people outside of a fee-for-service way, meaning your employed physicians and others. I don't think that's really the answer we're really looking for. We're really looking for highly productive physicians, and can you pay them just guarantees in flat amounts and not based on productivity and have that really work? That, I think, is an open question that's being more debated than I would have ever thought possible, and we'll see how that sort of evolves. We talked about E, the core goal of any hospital or health system, depending on how they define their market, is to be the go-to hospital in their area and to be such that payers and networks can't go around them. Again, if not dominant such that payers and networks can't go around them, they want to be so good in certain areas that they're needed for those areas and that they've got such a draw for those areas. Hospitals have to be high quality, critical mass. We'll talk about that more later. Again, we've talked about G. H is something I think is fascinating. Most of the major chains reported decreases in earnings the first quarter of the year. Some of them reported slight increases in April. Hard to understand exactly the different factors. At least at the major hospital chains, the biggest thing talked about was a decrease in inpatient cases. If you look at, there's a great Kaiser study that shows that the slowdown in healthcare inflation is based 77% or so based on the slowdown in the general economy, and I think there's probably a lot of truth to that, though there's debates about those numbers, of course. What we're seeing nationally is very tepid economic growth coupled with increased taxes and coupled with the 2% sequester reduction. If you essentially had growth of 1 to 2% and then through taxes took 3 to 4% out of the private economy and also took another 2% out of the government payment part of the economy, at least a segment of it, you're looking at 1 to 2% growth compared to 4 to 5% of money out of the economy, and it's hard to understand in some ways, other than sort of the amount of borrowing the country's doing still, how you're not already in a contracting standpoint or a correction situation. Some of the European economies are now showing corrections or actual, recession again. And it's hard to see how we don't get there or get pretty close to it when you combine the sort of tepid growth with the increased taxes and the sequester payments. It's hard to see how we don't get very close to zero economic growth. At the end of the day, if 70, 80% of what really happens in healthcare is correlated to the rest of the economy, that's not a good sign for any of us, but hopefully not dramatically problematic. You still see, again, stagnant unemployment and the big chains showing decreased profits versus increased profits, and we'll see how that continues through the rest of the first half of the year and the rest of the year. The next slide, the next topic we're going to talk about is physician-hospital alignment generally. Here, we talk about consolidation at 4 levels. The first level is hospital consolidation. You're seeing a lot of that. You had a dramatic decline in it the first quarter this year, but I think overall you continue to see many, many independent hospitals very, very concerned about their ability to stay independent, and I think that concern will continue to drive hospital consolidation. On the flip side, I think you see more and more big health systems concerned about how much additional obligations they're taking on in acquiring additional hospitals. So you see some slowdown in some of these transactions in the amount of potential purchasers or partners on the other side of transactions. But I think we'll continue to see the evolution of, the moving away of independent hospitals just because there's too many risks, too many issues. We talk to smaller hospital boards, and when I say smaller, 50 to 150 million a year in revenues, and we see board burnout, and we see great concern about what just does the future hold in terms of healthcare, and can they survive as an independent hospital. The other kind of consolidation we see, hospital physician consolidation, and we'll talk about that more in this set of slides. The third kind is payer consolidation, tremendous consolidation amongst payers. This has led hospitals to be more reliant on one or two payers in most markets. At the end of the day, most of the consolidation has led to 4 core payers in the country, some variant of a Blue Cross plan, United, Cigna, and Aetna, very much market to market. Obviously, Humana is very big in the Medicare Advantage plans and some other markets, but you really see largely in most markets a hospital system used to have a choice to not deal with the payer. Now, every market has 1 to 2 principal payers that, together with Medicare and Medicaid, hospitals have to deal with. They almost have a very hard time not dealing with. In terms of the last type of consolidation is payers who are still sitting on billions of dollars, literally, starting to invest in their own provider networks as a hedge against hospital power. You've seen that play out dramatically in Pennsylvania, but you also see it on a much smaller scale in lots of other states where payers are more and more owning provider networks of all types and sorts. In terms of strategies on physician-hospital alignment, clearly right now the dominant strategy is moving towards employment. It gives hospitals lots of flexibility under the Stark and anti-kickback laws, gives them a ton of flexibility to go to market with an integrated system. So the clear preference has become employment. That stated, we still see hospitals in lots of markets focusing on a whole host of other efforts at alignment, whether, co-management agreements, joint ventures with specialists, medical directorships, vice presidencies, all kinds of things, co-management agreements, and then some other variations which are probably less the preference. But in terms of these alignment strategies, one of the fascinating stats I read in the last couple months was the concept that 80% of all physicians have a financial relationship with their hospital today. And so even if only 50% are employed, there's another 30% that have some financial relationship, and I think this just grows out of multiple different things. Hospitals, we need to be close with their physicians for a whole bunch of reasons, but also needing to, to build their networks for managed care purposes. But I think some of it rebounds to it. I don't know, not all 80% of it, but some percentage of it is based on really just ultimately protecting referrals and so forth. But we continue to see hospitals, number one, want to be employers of the physicians. Number two, if they're not, they still want to have financial relationships with their top admitters because they can't afford not to. And this really goes to the next slide where we've talked about this. Again, we've seen hospital systems, $200 million systems, 25 top admitters. Just losing 4 of those in the right specialties can be devastating to hospitals' financial performance. So there's tremendous focus on what do we do to assure that we're tight with our top 25, top 30 admitters. Obviously, the bigger the system, the less reliant you are on a small handful of physicians. It's one of also the great strengths of being larger is you amortize your risk to a physician going free agent and going AWOL to another system. The fifth item on this slide is the concept of loss of dollars per physician, and this is very perplexing, at least on its face. Hospitals, when you talk to hospital leadership, when you look at studies on the professional side, just professional revenues versus professional expenses, you see hospitals losing anywhere from $50,000 to a couple $100,000 per physician, at least theoretically. And then you look at the question of, is this sustainable in the long run, or is it explained by the fact that studies like the most recent Merritt-Hawkins studies show that each physician who's employed, on average, might be worth $1.2 million to $1.4 million to a hospital in terms of upstream or downstream referrals. So even though they're losing money in the physician professional side, they're making it up on the technical side. Another fascinating study, which was also a Merritt-Hawkins study, I believe, it showed at one point that on average, a physician who was compensated, let's say $600,000 a year, was worth two-way system 5 to 10 times more than that in technical fees and other types of business. So you get into this great question of, are hospitals buying networks to prepare for managed care and the changes of managed care, even though we're still living in largely a fee-for-service world, or are some of the acquisitions and the losses per physician explained by some of these stats that show how valuable physicians still remain in a fee-for-service world? And again, what you see in the acquisition of physician practices, the employment of physicians, is somewhat a regression to the norm in a bell curve. Your first X number of physicians might have been carefully selected, great physicians that really do economically work out. But as hospitals have adopted an all-in strategy, they've got carrying costs on not just the first 10, but all 1,000 physicians they employ. And it might very well be that physicians 700 to 1,000 are truly economic losers for the hospital, and then trying to figure out why you have them. Is that defensive to keep somebody else from getting them? Are you still doing okay on their technical fees? Or ultimately, do you need to prune your physician network? And those are questions people look at. Number 6, one of the key things we've seen over the last decade evolve is systems become much better employers of physicians, excuse me. When we've seen hospital administrators get good at this, it's when they start taking a very positive attitude towards their physicians versus a negative attitude. We view it in terms of organizing the practice. 3 core things a practice has to do right to succeed long term, meaning here a hospital-owned physician practice. First is the practice has to have a relatively pro-physician culture. Has to be positive to the physicians, has to provide autonomy to the physicians, can't be a hardcore top-down model, just almost unworkable for highly, highly paid professionals. Can try it. Most systems have failed with it. The second concept is the practice has to be highly competent. It used to be you were guaranteeing physician salaries, you're buying their practices, and so some hospitals didn't pay enough attention to how well they were actually going to operate the practice afterwards. Today, it's got to become a core competency. Billing collections has to be done well. Scheduling has to be done well. Cannot tell you the amount of complaints I hear from physicians about how their hospital schedules their appointments or gets their phones answered. Seemingly silly things, but critically important to the physician's relationship and communication with their patients. Third is compensation. We're a fan of the fact that compensation doesn't have to be the highest, it doesn't have to be the best, but it's got to be in that range of fair. It's got to be in a spot where the physician doesn't feel disrespected each day and thus constantly listening to offers to go elsewhere. What you want your physicians basically getting paid fairly. You don't want the ones that require to be paid at the top 1% of everything. You want them paid fairly, you want them paid well, and you want comp then off the table so you can focus on running a great practice and doing great things. But it's got to be fair. You can't underpay, but generally you can't make it work either by simply overpaying. The other things are more important. Fair pay is critical. Sustainability, again, a key question for physician hospital, employed physicians, in any kind of joint venture, any physician model. It's just essentially the sustainability of it over time, economically, and as hospitals end up with underfunded pensions, and if they actually see the reductions in revenues that some have prognosticated, are these physician networks really sustainable? Some systems view it as the absolute crown jewel of their system. Was listening to a brilliant CEO talk last month about how he views himself and their system as largely out of the new bricks and mortar business and much more so into the business of now looking at growing out their physician network and making other investments, much less focused on the billion-dollar building and much more focused on great operations, great employees, great physicians. Eighth, and we'll talk about this again later, just no shortage of prognostications of physician shortages. Again, this is very different from market to market. If you're in the large urban markets, where some physicians view it as the place to settle, you know, the sort of New York's, LA's, St. Louis, San Francisco, Chicago's of the world, Atlanta's, big cities, you know, where people want to settle, you're not so much looking at as much of shortages. But if you look at rural and smaller communities, trying to recruit has become absolutely brutal. All the studies show a lot of retiring physicians over the next couple decades, and not nearly as many coming on board to fill the gap, plus the continued growth in population. Ninth is one of my new favorite terms I hear often, which is the concept of leakage. This is not the leakage that revenue cycle firms advertise. Help us avoid leakage in your collections. This is leakage of that physician works for us. Why are his cases leaking to a competitor? And again, with physician-hospital alignment, such a fascinating blend of legal and business concerns. On the legal side, wanting to make sure that you're not requiring referrals unless you could do so under a proper Stark exception. From the situation of the business perspective, looking at it quite differently of we're paying that person a ton of money. I know we're only paying him for professional services, but it sure does irritate our board that he or she is taking his orthopedic cases to another facility, or he or she is doing anything in another facility. And I think just more and more of that term you hear talked about, why are cases leaking away from our system to other systems. The sort of, let me move on. So that's physician-hospital alignment. We touched earlier on some general trends and strategic issues. The next thing I thought we would touch on is sustainability of the independent hospital. Then once I get past these few slides, I'd like to turn over to a few of the questions that I've seen posited so far and try and touch on those. In terms of sustainability of a hospital, independent hospital, we start with really asking the independent hospital, 3 or 4 core questions. This is slide 8. Can it be the go-to hospital in its area? Can it position itself such that payers need the hospital, that they can't go around the hospital? It used to be that a couple hospitals here in Chicago had such market strength that whenever a payer tried to exclude them or had difficult payer negotiations with them, they ultimately had to come around because the population of employers wouldn't live with a network that didn't have those hospitals in it. As the world's gotten a little bit flatter, and yet there's still hospitals here that have that distinct advantage, it's become a much more balanced situation between those hospitals and payers. But I think overall, particularly in small, mid-sized communities, can you be a dominant hospital that people can't get, can't do business without? Can you afford? Can you put the investments into your system to position yourself in such a way? In terms of 6 key factors that I think were fascinating from a Kurt Salmon Associates study in terms of assessing, the sustainability of a hospital, and I like these. One was geographic. Do you have serious barriers or not? It might be that you're in a small, mid-sized community and nobody else could afford to build a hospital there, or it might be that you've got a certificate of need restriction, something that gives you a serious geographic barrier that in and of itself is very, very valuable. Second concept, what's your payer mix? And often there's stuff you could do about your payer mix on the margins, but if you are in a serious urban area that's heavily medicated, there's not a lot you can do about it, and it's figuring out if you can make an institution go with what is inherently a very challenging payer mix or not. Third is, how deep is your physician alignment strategy? How closely tied you up with physicians are you? Are you in a spot where if you lose a few, you're still fine, or are you in real tough shape if you lose a few key physicians? Can you afford to build out a more extensive physician network? I heard one brilliant CEO say at one time, look, I don't want to have to buy and own those physicians. I'm going to lose money on them, and all I'm doing is getting the same amount of business I already had. The flip side being today, people are very scared not to employ those independent physicians that are so important to keeping the lights on and doors open at their hospital. But do you have a deep enough physician network and a deep enough caseload that you know your hospital can survive day in and day out? Asset base, you could be a very healthy hospital that's 80 years old, and you've got to do an outrageously expensive replacement hospital, and that could be enough to force you to not be able to stay independent. You know, do you have decent margins? Is your asset base in a horrible need of, you know, refurbishing, renovating? How bad will it be? How expensive will it be? The fifth item in terms of independent hospital sustainability is cost structure. Do you have a low cost structure, a high cost structure? Are you overstaffed? Do you have such debt, or do you have unfunded pension debt that no matter what you do on the margins, it's very hard to see yourself as long-term sustainable? In contrast, you have decent margins and not looming problems, not huge debt payments that have to be recalibrated or refinanced, but you're in relatively good shape in terms of your quality situation, in terms of your, cost structure and the cost to continue to operate day to day. And does it look okay for the foreseeable future? Even if you had some drop-off in revenues, do you have some cost you could cut either through employment attrition or otherwise to be able to maintain decent margins and survive? The sixth question in terms of sustainability, which I think is just a fascinating question, is one that goes to quality of care rendered at your institution. I view the first litmus test is, if you're a board member, would you take a family member to that hospital? Or for anything beyond a very minor ailment, does all care go someplace else? I view this as an initial litmus test. When I sit in a hospital system board meeting and it's a $200 million hospital and it's clear that nobody in the room wants to take their family member or themselves to that hospital for any kind of serious care, well, it's time for that hospital to look much more seriously at the affiliation strategy. At the end of the day, quality is important. I think it's more important than ever. Whether systems will truly get paid for real quality, I don't know. Can you develop such a high-quality reputation that you're going to get paid special for it? I don't know. But you have to hit a Maslow's hierarchy standpoint. It's just like paying physicians fairly, that you're not knocked out of the game of patients and networks based on quality. In terms of at least the lowest common denominator, you have to be there. Can't be in a spot where people just don't want to go to your hospital because of perceptions on quality. And all of us are familiar with different hospitals throughout the country that everybody thinks of in a certain community as, oh, we can't send a patient there. That's thought of as Death Valley, or that's thought of some way otherwise. You can't be that hospital. Some examples we've seen of hospitals that ended up going bankrupt. One hospital took on way too much debt, not nearly enough patient base, ended up going broke. It was an early startup. Second hospital, just a horrendous set of quality problems early on, number of deaths. That was enough to essentially lead it to a place that nobody ever wanted to go to. Third hospital, this was years ago, made a big conversion on billing and collection systems and revenue cycle systems. They did it, in this case, overseas. Was a complete disaster, and it was enough to cause that hospital into receivership. And finally, the fourth institution, essentially the loss of just a small number of key physicians of their top 25 admitters, led them to essentially be on the brink of bankruptcy, not actually dead. But let me take one moment and see if there's a couple of questions. Okay, I see a couple of the questions, but some of them are more detailed for me to answer at this time. So let me continue on with the structure, the discussion, and then we'll see if we can come back to this at the end, because I'm getting loaded down trying to read 3-paragraph questions on my email. In terms of the development of ACOs and just a handful of core comments on ACOs, still the vast majority of ACOs essentially hospital-centric, built by hospitals, but there are a growing number of percentage of them built by large physician groups. There's a couple of great quotes, and these are already a year or so old, or not that long, from different thoughts from people like Tom Scully, an investor in healthcare and former head of CMS and a really smart guy, Jeff Goldsmith, and a couple others that are in the literature on some of their thoughts about where ACOs are and where they're going. I think, again, these stats are some of these quotes are 6 months old, some of the stats are about 6 months old, but I think you're still in a situation where, in terms of ACOs, the jury's still sort of out as to how effectively they'll operate and how much a percentage of the patient population will really be served by them and how they'll be implemented. I think, again, we talked about earlier, there's prognosticators that believe the movement towards larger, if not capitated models, but full risk-bearing models will lead to there being ultimately 40 to 50 or less systems in the country. People on that argument say that the healthcare system is still highly fragmented. The biggest operator has 4% of the market. It's very different than other industries, so expect huge amounts of consolidation. The flip side is I look at systems accumulate smaller hospitals. Some of them are struggling more than I think they expected to digest them, and the more that they're spread out, I'm not sure that they really give them market power or positioning power with their payers in terms of whether we'll actually get to that spot. In terms of the ACOs and the bigger fears or thoughts that are here right now is, in many states, it's the concern that individual employees or small employers will end up seeing patients migrate from fee-for-service to healthcare exchanges, which will still be fee-for-service, but on very low reimbursement rates. We hear a ton of concern about that kind of migration, more than we hear about how ACOs will play out or how we hear about shared savings agreements with payers will play out. We also have, you have a few systems in the country who have really gotten wholly after bigger managed care models, bigger risk, other types of models of payment. I think most CEOs and CFOs who are running health systems and hospitals, if they're still surviving 80 to 90% on fee-for-service, and they don't have the critical mass to almost be like a Kaiser with almost its own insurance program, I think are very concerned about the migration away from fee-for-service, and I think it will probably go a lot slower than people anticipated. I think many systems have their foot in the door, and they have to be constantly in very close discussion with payers about new emerging models of pay, but very concerned to actually take the jump other than incremental pieces. And it's no wonder that they are in this position. If you have ongoing expenses, a monthly nut of $25 million a month, and you're a hospital that runs a certain way, from a revenue model perspective, you're very concerned about taking that migration or evolution to a different method if they have to. So for many health systems, unlike the few of the proud that have gotten way out in front of this, they're much more focused on, let's be at the table in all these discussions. Let's make sure that we're actually experimenting with these things, ready to do it, have the network in place to do it, but let's hold off on actually moving away from fee-for-service as long as we possibly can. And I think it's a fascinating discussion and debate in boardrooms and amongst senior leadership as I think people continue to thrive and survive off of fee-for-service, but understand that's a buzzword that Washington doesn't want to hear. So I think it's just an absolutely fascinating sort of discussion. The fifth set of issues we're going to talk about, I've categorized as what we call other issues, not a very exciting title, and just I think 6 or 7 of these that I think have a bigger impact on healthcare than people may be prepared for. One is, just physician burnout and leadership as you look at middle-aged, older physicians and the change in the physician workforce, just less interested. Periodically we see physicians that are doing outrageous RVUs, 20,000 RVUs, 30,000 RVUs, outrageous WRVUs. And again, you could say nobody should be doing that many RVUs, which might be a fair statement, but you have this percentage of physicians of a certain generation that were just crazily productive and really driven towards working a lot. And as those physicians start to burn out, as they don't get rewarded by the system, as they're more and more concerned about the system, I think there's a whole level of physicians that are burning out that are not just at that kind of crazy productivity, but just your sort of above average physicians looking at more and more, when do they retire, when do they slow down, and you have the number of doctors in the system, in the pipeline, to fill those spots. In terms of access issues with burnout and shortages, again, you know, it's different in different parts of the country, but I know even the most connected of folks have a hard time getting access to the specialists they want to see without a special connection, a special call, a special something. And you talk about what that means for access for the average person to specialty care in many markets, and I think you'll see that issue really grow, the access problem, and in some ways not even noticeable till it's so bad that people really do notice, till like the average person actually notices, God, I wanted to see my orthopedic surgeon, I couldn't see the one I wanted to see, I couldn't see the one I wanted to see after that, so I ended up seeing the 10th on the list, you know, who's had 20 malpractice cases in the last 3 years. And I think more and more, whether it's that kind of example or just simply just can't get in, see who I want to see when I want to see them, I think more and more you'll see that in this country. The question on hospitalists, it used to be as hospitals were acquiring physicians, the physicians they were acquiring were very negative towards hospitalists. They viewed them as sort of competitive with them. Now you see the growth of hospitalists very much supported by the independent practices and the employed physicians of hospitals as, God, the hospitalists really take a burden off of us rather than hurt us. And you see now hospital systems clamoring to get more hospitalists, whereas not too long ago that was a different view of the world. Again, burnout, we see less and less physicians with sort of the unbelievably productive RVU numbers. I know there's mixed thoughts on that kind of issue. You've got much more of a gender balance amongst physicians coming out, and a number of things that just have some impact on supply of the number of physicians and potential shortages. And I think, again, it's most acute in some of the smaller areas. One of the fascinating next slides, and you're starting to see some of the, going forward, a few slides past physician burnout. There's a couple fascinating quotes on physician burnout that are in here as well, and just shortages. The next quote was on sort of the knee industry, the knee business. I think it's fascinating when you go into hospital systems. I was at a hospital last year, 70% of the revenues comes from orthopedics. Nationally, 12.5% of the healthcare dollar is spent on orthopedics. You know, if you go to the AOS show, American Academy of Orthopedic Surgeons, there is no more popular show in the country with 27,000 orthopedic doctors attending each year. When you see the numbers, $9 billion spent on knees alone last year. When you go into various different hospitals and see how important orthopedics is, there's no great surprise about this. You see the big orthopedic device companies for the first time, some of them having small layoffs, working very hard on their overseas expansion, working very hard into exploring growth into spine and other areas, but there's no way around it. It still is just a huge industry and a huge part of hospital revenues and the healthcare system expenses. It's what I wonder. Many hospitals, in an effort like you know, France with the Maginot Line to prepare for the last war, 10 years ago built huge cardiovascular programs based on bypass surgery, and then saw bypass surgery drop down tremendously, precipitously, based on the development of medicated stents and other things. What I wonder is I see hospitals invest in spine programs, not so much orthopedic programs. Orthopedics, I think, will stay very significant, very important for a very long time. What I think is probably more akin to the cardio situation as the spine situation, where we see hospitals now investing lots of money, small hospitals investing big money in spine programs, you know, often based on the lure of spine dollars. And I wonder if those things, somewhat consultant-driven, somewhat revenue-driven, won't be akin to the investment in cardiology 10 years ago and turn out to be horrendous investments based on the fact that spine will just not remain as expensive as it is today, and thus as profitable to hospitals and surgery centers as it's been. I think that's sort of the fascinating next evolution outside of knees and outside of cardio is the growth in spine. We see every month a new hospital that's relatively small size investing lots in the spine program, and we just don't know if there's enough spine business to actually make this all work. Population health, one of the great fascinating questions about population health is, I see how it works, and people look at this population health in many different ways. I see how this works where one main hospital really owns an area, is the primary provider, and so all investments it makes into healthcare in that area, in some way we're bound to it in terms of lower cost, possibly, or better community health. I sort of see the population health concept there and how it works. What I'm still struggling to understand, and I'm sure many people will say that I am wrong to even have concerns about this or not understand it, is how population health will work truly in an area where there are, several different hospitals all competing for the general population. And I know that the smart people will say, Scott, you're looking at it wrongly. What you should really be looking at is the 5,000 patients that follow that physician, or the 2,000 patients that follow that physician. That should be the population you're focused on, and trying to square those issues with small populations run by specific doctors and specific ACOs or shared savings plans versus true population health, where, for example, when you talk about one system that's a dominant hospital in their area, Montefiore in the Bronx, traditionally Claremont Hospital in its region, it can really look after community health and understand where it's having a direct nexus and impact on it, or population health, where it's harder for me to understand in highly competitive markets how one party really gets out ahead of a population health area versus another. And I'm sure somebody can, shed light on it. I've heard the thoughts on, well, you're really talking about population health, so you're a community that follows you to the ACO, and that may be the case. Health information technology, I think, again, this has been the situation with HIT is, I think, one of the most fascinating ones in the country, and it's endemic of other trends and problems we have in the country. If I look at, over the last month, two of the great institutions in our country, the American Airlines and Chicago Board of Options, were both essentially closed for a day or two each based on information technology problems. And I think, essentially, when you look at all the investment in healthcare information technology, just getting to the spot of, I think, a tipping point in critical mass where people are starting to buy into the concept, yes, it's actually useful. Yes, it causes some reductions in productivity. Yes, it's leading to some upcoding. But by and large, we're starting to see some of the benefits from it in a more serious way. I think that's a positive. The flip side is, what I don't know of is whether the country has the staff and the support, and there's a great article in this in the Wall Street Journal, not so much on healthcare information technology, but on technology graduates, to actually support all the systems that have been bought. And I think as you try and, there's no place, if you talk about unemployment in this country, it is serious. It might not be like the Spain 27%, but in IT and information technology, the people that don't have jobs are generally those that don't want to work, or those that are not truly into coding in the back office stuff. Those skills are in short supply. It's been quoted to us by several people that unemployment in IT is closer to about 2% versus the general numbers in the country, the 7.5% to 8.5%. And so I think that at the end of the day, the systems that get graded IT will start to really see serious benefits from it, and they almost have to view it as a core competency. The flip side is trying to band-aid IT systems, I think, is increasingly a problem. And I think even when you're throwing lots of resources at it, some of the best institutions in the country, i.e. the American Airlines and others, will have serious challenges, have had serious slowdowns and challenges and closures based on not being able to support their IT systems. I think we'll see a number of hospitals over the next year or so, next couple of years, report similar problems where the EMR is down or some part of their system is down, and they're just really in a bad spot. The last issue that I talk about in terms of other issues is the development of branding and quality initiatives with the Mayo Clinics of the world, the Cleveland Clinics of the world, and some of the other great institutions in our country, and whether those institutions will truly be able to partner with other institutions and improve quality at those other institutions. whether they'll be able to really leverage something beyond the name of Mayo and Cleveland Clinic. I see some places where I think this is working quite well, where parties are truly doing joint efforts together with Mayo Clinic and their institution. I'm not yet to the point where I understand deeply enough how a Cleveland Clinic affiliation with a 10-hospital system is going to impact that 10-hospital system in a positive way. And again, I know contractually there'll be all kinds of ways that they're going to, but it'll be interesting to me to see if those things actually work. If you could have that kind of affiliation and really over time improve the true quality of care and branding and what that other health system can do, so it actually makes a serious incremental difference in their delivery of care. Kathy and Katie, that's the end of my prepared comments. I would encourage people to email me questions at sbecker@beckershealthcare.com, and I'd be happy to respond to those questions by email for people that have questions, if that's okay with people. Kathy, you want to make sure I said the email address right, to sbecker@beckershealthcare.com?
Sure. It's sbecker, B-E-C-K-E-R, at, I don't think it's at becker.com. Katie, can you tell me what that is? sbecker@beckershealthcare.com. And so if you want to email Scott Becker questions, please do so at sbecker@beckershealthcare.com.
Right, and I want to thank people very much. If you have comments on this session, whether you, if you hated it, and email me, we'll give you a free invitation to next year's annual meeting to join us. If you liked it and have comments on it, we'll give you 2 free invitations. But please feel free to email me with comments or questions, just so we make sure that what we're doing is relevant to the audience. Thank you very much.
Okay, thank you, Scott. And I want to thank everyone for attending today. As a reminder, any questions that you asked, we will follow up with you on them. This will conclude today's program, and have a wonderful afternoon.